Osteoporosis, which was published in 2022 in American College of Rheumatology. So I will be covering these topics. What was the background, how the method was used for giving the recommendation, and whom we should screen for, and how to stratify the risks, and when to reassess those patients, and what are the pharmacological choices with age, and and with the fracture risk category. And these guidelines also included special populations like children, pregnancy, transplant recipients, and patients who are on very high doses of glucocorticoids, and patients who are ongoing osteoporosis treatment, and there is history of treatment failure, and or there is discontinuation, and how to change in sequential therapy, and what are the key takeaways from 2017 guidelines. So why this thing matters? Because sorry, because 1% of the, according to this recommendation, 1% of the US population is on the
डॉक्टर
long-term
मनोज
glucocorticoid. जी,
डॉक्टर मनोज आपकी स्लाइड ना बहुत छोटी दिख रही है बॉस। जैसे
अच्छा
वन
सर,
परसेंट लिखा है ना, उसके नीचे जो लिखा है वो नहीं पढ़े जा रहा है यार।
अच्छा कैसे करूं सर? हाउ टू?
फुल स्क्रीन नहीं क्या ये?
फुल स्क्रीन ही है मैम। अभी है मैम।
जब आपका जो उस स्क्रीन है वो छोटा दिखाई दे रहा है, बैकग्राउंड ब्लू दिखाई दे रहा है।
हाँ हाँ, अभी आप जूम कर रहे हो ना बॉस, तो आउट ऑफ प्रोपोर्शन हो रहा है वो।
अच्छा अभी देखिए सर।
मैटर नहीं 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 नहीं, आउट ऑफ प्रोपोर्शन हो रहा है बस। मैटर डिसअपियर हो रहा है वहां से लिखा हुआ।
अच्छा अभी ये देखिए, अभी दिख रहा है सर?
नहीं नहीं, वो तो मतलब कोई चेंज नहीं हुआ ना वो।
साइज सेम
स्लाइड
है।
व्यू वो आपने कॉलम वाला किया हुआ है, वन स्लाइड पर वो करके देखो।
एक मिनट
प्रेजेंटर
शो
व्यू,
करता हूँ।
सेलेक्ट प्रेजेंट, हाँ ऐसे। अब ये वाला व्यू, हाँ
हाँ यही किया हुआ है मैंने।
ये किया।
हाँ जी।
तो क्या इसमें मैक का प्रॉब्लम?
ठीक है।
सो
हाँ, वो पढ़ा जो बोलोगे ना वो फॉलो करना मुश्किल है। चलो एनीवेज ठीक है।
So according to this guideline, 1% of the US population is on the long-term glucocorticoid therapy, and within 3 to 6 months is the window for most rapid bone loss when we start with glucocorticoids. And 12 months is the peak time of fragility fracture risk in in patients who are on long-term glucocorticoid therapy. And for the dose, if a patient is taking more than 2.5 milligram per day dose, then there is increased risk of spine or hip fracture risk in those patients. So how the recommendation were developed? The recommendation were developed from the 2017 up to from the 2000 up to the 2017 research review articles, and up to the January 2022, including the PICO questions, patients, intervention, comparison and outcome questions, and grade methodology was used for giving the evidence as high, moderate, low, or very low. And the patient and the voting panel was made, who are the experts and multidisciplinary team, which required more than 70 equal to 70% consensus on both the direction and strength of the each recommendation. And the patient panel was also present, with patients who are on long-term glucocorticoid induced osteoporosis treatment, or parents who are whose childs were treated with glucocorticoids, and they also reviewed the evidence, and they shared their perspectives, and that informed the voting panel. So then they made two recommendations: strong recommendation or conditional recommendation. Strong recommendation were applied to can be applied to all or almost all patients, and there is high confidence that the benefits clearly outweighs the harms. And there is very low certainty evidence that if the action is low cost or benign or without harms. And if conditional is said that when there is it is supported by lower certainty evidence and there is sensitivity to individual patient preferences and circumstances, and sometimes the cost some because of some cost that influence the decision making. So this risk assessment should be done in all patients who are more than equal to 18 years of age, who are initiating or continuing glucocorticoid therapy for more than 3 months with dose of more than 2.5 milligram per day. And it is usually done with bone marrow density with vertebral fracture assessment or spine X-ray. This was strongly recommended for all patients. And fracture risk assessment tool can be used only for more than equal to 40 year of age. And in this also, glucocorticoid dose correction is needed when the patient is taking prednisolone dose more than 7.5 milligram per day. And in the risk history, there should be taken dose, duration, what is the pattern of glucocorticoid use, is there any alcohol history or smoking history, is there any hypogonadism, is there any prior fracture history in the parents or in the patient, is there any low body weight, parental hip fractures, falls, patients who's having rheumatoid arthritis, malabsorption, inflammatory bowel disease, thyroid or liver disease. These all included in fracture risk assessment tools. So after getting the fracture risk assessment tool, this risk assessment are divided into very high, moderate, and low risk of fractures. So in the very high fracture risk history cases, there is if there is patient is having prior osteoporosis fracture or T score is less than minus 3.5, or the fracture risk assessment tool showing the major MOF is major osteoporotic fracture more than equal to 30%, or hip fracture risk is more than equal to 4.5%, or patient is taking high dose glucocorticoid that is more than 30 milligram per day. And high fracture risk is when T score is less than equal to minus 2.5 or but more than minus 3.5, or major osteoporotic fracture risk is 20 to 30%, and hip fracture risk is 3 to 4.5%. In moderate, major osteoporotic fracture risk is 10 to 20%, and hip 1 to 3%, or T score is between minus 1 to minus 2.4. And in low risk, there is fracture risk assessment tool. Major osteoporotic fracture risk is less than 10%, and hip fracture risk is less than 1%. T score is more than minus 1, and there is no other risk factors. Because fracture risk assessment tool is considered can be done only in more than 40-year-old. So for patients who are less than 40-year-old, there is only a very high category, moderate, and low category. There is no high risk category. So for very high category, that is when patient is having prior fracture risk history, or glucocorticoid dose is more than 30 milligram per day, or cumulative dose is more than equal to 5 gram per year. In moderate history risk is when glucocorticoid dose is more than equal to 7.5 milligram per day for more than 6 month duration, or Z score is minus 3, or there is a significant bone marrow density loss. And in low risk, there is no risk factor other than the patient is taking glucocorticoid treatment. So what is FRAX, that is fracture risk assessment tool? In this, there is a method where we put there is a calculator where we put patient's age, sex, what is the dose, is there any prior fracture history, or patient is having any prior fracture history, and patient's alcohol, smoking history. Many things are put in that tool. And then the major osteoporotic fracture risk and hip fracture risk come out in the 10-year probability risk. So it is only validated for more than equal to 40 years of age. It is not validated for less than 40 years of age. And it also underestimates the risk at very high glucocorticoid dose when patient is taking more than 30 milligram per day. And it also doesn't count force, fragility, or number or timing of prior fractures. And in those patients, if patient is taking glucocorticoid dose more than 7.5 and less than 30 milligram, then this glucocorticoid dose correction is also applied. With major osteoporotic fracture is multiplied by 1.15, and hip fracture, for calculating hip fracture, should be applied multiplied by more than 1.2. So, when we should reassess those patients who are on this risk assessment? So, when patients who are low risk and who are not on osteoporosis treatment, we should reassess those patients every 1 to 2 years. And patients who are moderate risk and those who don't want to didn't start their treatment, they should be reassessed every 1 to 2 years. And patients who are on moderate, high, or very high risk and who have started osteoporosis treatment for more than 1 year, they also should be reassessed every 1 to 2 years. And patients who have stopped glucocorticoids treatment and remains moderate to very high risk, they should continue osteoporosis treatment. For patients who are on glucocorticoid, they should be fundamental care should be given to every patient who are from low risk to very high risk. That is calcium, vitamin D. Vitamin D is in the dose of 600 to 800 international unit per day, keeping that serum vitamin D level between 30 to 50 nanogram per ml. Calcium dose is 1000 to 200 milligram per day for adults. There should be lifestyle modifications like smoking cessation and alcohol use less than 2 servings per day. There should be balanced diet and healthy weight should be maintained. For and patients should be doing a regular weight bearing exercise to for all risk for all patients who are on glucocorticoids. Then the how to start this treatment in glucocorticoid who are very high fracture risk. There is strong recommendation for starting of oral bisphosphonates over no treatment based on consistent fracture reduction data. Parathyroid hormones or parathyroid related peptides should be preferred over anti-resorptive agents like bisphosphonates or denosumab as in initial therapy because of anabolic effect, which can be blunted if bisphosphonate is used first. And IV bisphosphonate, denosumab, or ramucirumab can be considered over no treatment when oral bisphosphonate is not appropriate. And raloxifene or ramucirumab only in patients who are intolerant to other agents, given known cardiovascular or thromboembolic harms. For high fracture risk patients, there is strong recommendation for oral bisphosphonates or no treatment, and parathyroid hormone or parathyroid related peptide or denosumab can be preferred over bisphosphonate. Both show superior bone marrow density gains in glucose-induced osteoporosis treatment compared to bisphosphonate. And IV bisphosphonate, parathyroid hormone, or denosumab can be preferred over raloxifene and ramucirumab. And there is strong recommendation that there should be no two different osteoporosis treatment can be given at the same time. For moderate fracture risk, oral or IV bisphosphonate, denosumab, or parathyroid hormone or parathyroid related peptide can be considered over no treatment. And ramucirumab and raloxifene should be avoided, except in patients who are intolerant to other options. For low fracture risk, there is no pharmacological therapy required. Only patients should be continued calcium, vitamin D, lifestyle modification, or exercises. Then a recommendation for adults who are less than 40 years. As I already told, there is no high risk category in this patient. For moderate risk, oral or IV bisphosphonate, denosumab, or parathyroid hormone or parathyroid related peptide can be conditionally recommended. Patient should be avoided ramucirumab given the cardiovascular and stroke risk in these patients. Denosumab or parathyroid hormone should be used even with caution in patients who are on with open growth pellets and very high risk defined by prior fracture or glucocorticoid dose more than 30 milligram per day or cumulative dose more than equal to 5 gram per year. There should be a conditional recommendation of oral or IV bisphosphonate, parathyroid hormone, or denosumab. And there is conditional recommendation against aloxifene or romosozumab in this age group. Parathyroid hormone or romosozumab reserved for patients who have closed growth plates. And these are recommendations who are with adults who are receiving very high dose glucocorticoids, like more than 30 milligram per day or cumulative dose of more than 5 gram in a year. Then the oral bisphosphonate should be considered over no treatment, regardless of the fracture risk assessment tool score and bone mineral bone mineral density score. And parathyroid hormone or parathyroid related peptides should be preferred over anti-reabsorptive agents at this exposure level. IV bisphosphonate or denosumab can be considered over no treatment, and raloxifene or ramucirumab only in patients who are intolerant to other agents. Then the special populations like patients who want to become pregnant, bisphosphonate can be considered who are which are having short half-lives. Otherwise, long half-life bisphosphonate should be avoided. Denosumab can also can cause fetal harm, so it should be contraindicated. It is contraindicated, and parathyroid hormone or parathyroid-related peptide can be used if the growth plates are closed. Then patients who have recently gone solid organ transplant or patients who are having chronic kidney disease with mineral bone disorder. Patients who are having solid organ transplant can and with estimated growth glomerular filtration rate is more than 35 ml per minute, and there is no CKD or with major mineral bone disorder. Parathyroid hormone, bisphosphonate, denosumab, or raloxifene can be considered. Ramucirumab should be avoided due to potential harm in this population. And expert evaluation should be recommended if patients are having chronic kidney disease with mineral bone disorder. If patient is having renal impairment with estimated GFR is less than 35 ml per minute, this one should be avoided. And if patient is having renal osteodystrophy or hyperparathyroidism, then denosumab and parathyroid hormone or romosozumab dose adjustment is needed. Denosumab may cause prolonged or severe hypocalcemia if the estimated GFR is less than 30 ml per minute. So calcium levels should be monitored closely. Then in children and young youth who are aged 4 to 17 years, patients with optimum age, appropriate diet, calcium, vitamin D, and regular exercise program should be considered. They should be not be they should not we should not start bisphosphonate treatment in this low risk group. But in high risk group who's having osteoporotic fracture history or glucocorticoid dose is more than 0.1 milligram per kilogram per day, then oral bisphosphonate or IV bisphosphonate can be considered based on low certainty evidence for preventing recurrent fractures. Then the patient who are already ongoing treatment and the initial treatment fails. Like there is a new osteoporotic fracture occurs after 12 months of treatment.
Dr. Manoj, are you still there?
Who are on osteoporosis treatment for more than 1 year, and there is new osteoporotic fractures. Then oral bisphos, a patient was taking already oral bisphosphonate, and there was a suboptimal response. Then we can switch over to IV bisphosphonate, denosumab, romosozumab, or parathyroid related peptides. If patient was taking denosumab first, then parathyroid hormones can should not be switched over because it can cause transient bone loss and at hip fractures. And if patient was taking parathyroid hormone first and we want to switch over to denosumab, we can switch over to denosumab because it can lead to continued bone mineral density gains. Then patients who have discontinued glucocorticoid treatment, then how to do sequential treatment. So if patient was taking bisphosphonates, then there is no need of sequential therapy on those patients. And the patient has a T-score of more than equal to minus 2.5, and there is no new fragility score. Then patient can stop osteoporosis treatment if patient is taking bisphosphonate. And if patient is taking denosumab, then we should start a bisphosphonate 6 to 7 months after the last denosumab dose. Because follow-up risk, delayed follow-up risk can lead to progressive vertebral fractures in who are patients or who are on denosumab. Then patients who are on parathyroid related peptide hormones, then follow with the bisphosphonate or denosumab. Bone gains can be lost over 12 to 18 months without follow up on therapy. And then those patients who are on romosozumab, then follow with denosumab or bisphosphonate to maintain the bone mineral density gains. Then medication safety with IV bisphosphonate, there is risk of atypical femur fracture risk. There is chances of osteonecrosis of jaw, and with oral bisphosphonate, there is chances of esophageal fasciitis or esophageal. Then for with denosumab, there is a rebound vertebral fracture can be rebound fracture can be done if they are discontinued without follow-up with bisphosphonate or with riloxifene. There is chances of venous thromboembolism or fatal stroke. With romosozumab, there is increased chances of myocardial infarction, stroke chances, and death can occur. And this should be avoided if patients is having history of stroke or myocardial infarction within 12 months. Patient who are on parathyroid hormone or related peptide, then they should be avoided in patients who have open growth plates, and their anabolic effect can be blunted if after prior bisphosphonate use. So if we are considering them, they should be considered before starting oral bisphosphonate. Then what's new compared to 2017 guidelines? Then if we see 2017 guideline, there was no outcome of the bone mineral density. Very high risk category was introduced in 2022 guideline only, and the anabolic response was preferred over the anti-absorptive effect. And sequential therapy guideline was also included in this guideline. And two new agents like abaloparatide and romosozumab were also evaluated for the first time. And this was patient-centered selection of therapy should be considered for between patients, clinician, and according to the patient preference. Then key takeaways are the always assess the fracture risk as soon as possible within 6 months for every adult who are who is taking glucocorticoid dose more than 2.5 milligram per day for more than 3 months. And every patient should be offer osteoporosis treatment with moderate, high, or very high fracture risk. And this osteoporosis treatment should be avoided in low risk adults. Consider parathyroid hormone or parathyroid related peptide as initial therapy in patients who are at a very high fracture risk. and plan for sequential anti-rheumatoid therapy whenever denosumab, parathyroid hormone, parathyroid-related or hormone, or denosumab is stopped. We should reassess the fracture risk every 1 to 2 year, whether or not the patient remains on glucocorticoid or osteoporosis therapy. And these recommendations guide us. They do not dictate care. Final decision rests with shared decision making between clinician and patient. Thank you.
Thank you, Dr. Manoj. It was a good presentation, big article, but very helpful. Can be used daily in our daily practice. Very helpful. मैम 2 मिनट डॉक्टर अंशुल सर के लें या पहले आप
Yeah.
स्टार्ट करेंगे?
Yeah, let's say because these topics are different, no? Let's say what Dr. Anchal has to add in glucocorticoid, and then I can start my.
Now,
Dr. Manoj,
may
you
I
can
welcome
unshare
Dr.
your
Anshul?
slide.
Okay.
May I welcome Dr. Anshul and please summarize in 5 minutes the takeaway home message and clinical daily practice points for all of us.
Yes, absolutely. So I have a few points here. So first of all is the teriparatide thing. So teriparatide, yes, it's one of the best molecules that we have, irrespective of gender. So romosozumab and teriparatide or abaloparatide, these are two options in anabolic therapies that we have. So romosozumab is strictly for postmenopausal osteoporosis, especially for women. All the data that we have in steroid comes from an extrapolation from the postmenopausal data. Teriparatide, I think Dr. Manoj has rightly pointed out, you cannot go from denosumab to teriparatide. You can go from teriparatide to denosumab or teriparatide to the bisphosphonates. Secondly, what's also very important is he spoke about the Frax correction. So that is also important. Also, the duration of what the drug has been taken, the classification is something that needs to be taken care of. So sometimes what happens is we put a patient is in a moderate risk or a low risk category, and the patient still gets fractures while on treatment. So that is an indication that the treatment is not working, irrespective of what the assessment on DEXA scan says. So it's time to move from, if the patient is on anti-resorptive, from anti-resorptive to anabolic therapy, because clearly it's not working. Second, again, osteoporosis is so it gets worse over time. The worst part is usually the initial first 2 to 3 years, where the deterioration happens at roughly a rate of around 12%, and then it settles down to a rate of around 2 to 3% per year. So, calcium, vitamin D, again, for children, it's very important because this is all being said and done, although a very important cause for osteoporosis, it's still reversible once we discontinue the steroid. And in fact, in children, it has been seen that there is a reversal of even vertebral bone structure after discontinuation of the glucocorticoids. But again, we need to discuss, it's a multidisciplinary action which we need to take, where the reduction of dosage can be done because vertebral fractures can be debilitating. And we have whole studies which have been done on the use of anabolics and the use of the bisphosphonates and everything. So we need to take a very shared decision, and it needs to be based upon the risk of fractures, as well as what the patient's frac score and what the patient's T score and Z scores are saying. Thank you. So we can.
डॉक्टर अंशुल, इसमें इन्होंने हर रिकमेंडेशन पे ये मेंशन करा कि बिस्फोस्फोनेट इज द गॉट स्ट्रॉन्गेस्ट रिकमेंडेशन.
Yes, because that
Yes.
has the strongest data. But if the patient has, so there are the categories that Dr. Manoj spoke about. So if the T score is less than 3.5, if the patient has imminent fracture risk. So imminent fracture risk is if in the last 2 years, the patient has had a vertebral fracture, that is imminent fracture risk, or fragility fractures. So that just directly qualifies the patient for an anabolic therapy. In a patient who has moderate high risk, bisphosphonate trials can be given, because we also need to consider that what will be the patient adherence. So romosozumab is officially not available in India. We get Evenity, and so that is one anabolic out of the picture. We have teriparatide, but we don't have abolaparatide. So teriparatide, again, it's a daily injection. Patient's adherence again is a big issue. So blanket, we can start bisphosphonates. But if we look at the pathophysiology of how steroids cause this, an anabolic would be better, because initially what happens is there is a sclerostin overactivation, which affects the WNT beta catenin path. So that affects both resorption as well as the new bone formation. And when we talk about bisphosphonates, it primarily stops. It's an anti-resorptive agent. It decreases the osteoclasts, and the benefits which happen over years. So that is where there is a 3 to 5 year window, and after that we can go for a holiday with bisphosphonates, even in patients who are not on glucocorticoids. So that's why it's the recommendation is the strongest evidence. Yes, we have with the bisphosphonates, but it's something that these are guidelines. We need to play it by the year. We need to evaluate the patient. We need to evaluate the patient for risks, whether the patient is overweight or not, the patient has previous fractures or not, what exactly is the indication for steroid, and what is the dosage. So 30 mg in itself qualifies the patient for, again, an anabolic therapy. So these are factors which need to be in communication with the patient and with the different teams. Also, what this ACR guideline has done is that it is classified very categorically in different categories, and the patient can move from within categories even on treatment. So even if the patient is on bisphosphonate and gets a fracture, shift the patient to teriparatide. The effect might be delayed, which it will be, because bisphosphonates delay action of any anabolic therapy, because there is no substrate for for teriparatide to work with. But over a period of 6 months to a year, once the effect wears off, the bisphosphonates do become a good choice.
And with the teriparatide, there is compliance issue with the patient. I have
Yes,
seen
so it's a daily injection. Yes, exactly.
yeah, patient does not want a daily injection. That is the biggest issue.
डॉक्टर अंशुल, एक बात पूछना चाहता हूँ, ये जो वर्टिब्रल फ्रैक्चर आ जाते हैं, ओल्ड एज फीमेल्स होते हैं ना, वो पोस्ट मीनोपॉजल होते हैं, तो उनमें हम टेरापेराटाइड अलोन इज सफिशिएंट?
So first 2 years, so अभी तक the indications and the approval that we have, वो 2 साल तक का था, up until 2020 for the risk of osteosarcoma. Now it has been extended. So the thing is कि if the patient has vertebral fractures, अगर last 2 years में हुआ है, तो imminent fracture is again high risk category. Best drug for such a patient जो आपने describe किया would be romosozumab. But romosozumab expense issue है and availability issue है, because it's not easily available in India. Available हो जाता है, but directly through company नहीं, it's very specific. So best drug is romosozumab, because it is both anti-resorptive as well as anabolic. But if we disregard because of the availability issue, teriparatide is the second best drug. And if the patient again refuses to take teriparatide, उसके बाद denosumab है. But teriparatide alone for 2 years, and then data switch trial था data switch. So data switch के अंदर there were 2 studies which were done. It was denosumab say teriparatide, and teriparatide से denosumab. So denosumab से teriparatide, of course, Dr. Manoj has told that कि नहीं करना चाहिए, क्योंकि जो denosumab का जो भी beneficial effect था, that is lost. And with teriparatide, but teriparatide to denosumab is a very good switch, and it should be done. So while the patient is on teriparatide, और किसी चीज का जरूरत नहीं है, because anything that we give, हम anti-resorptive अगर देते हैं, so it's only going to hinder the effect of teriparatide, not supplement it. Once we stop teriparatide, then we move to an anti-resorptive agent. We can choose and discuss with the patient कि denosumab करना है या फिर bisphosphonates करना.
Thank you.
Thank you, sir.
और एक साथ दो इस बहुत मतलब एंटी रिजॉर्प्टिव और एनाबोलिक्स एक साथ नहीं चलना चाहिए, तो भी है।
नहीं, एग्जैक्टली,
एट द
क्योंकि
सेम
मतलब
एक दूसरे का
टेरापेरेटाइड
इफेक्ट।
और
टेरापेराटाइड
टेरापेरेटाइड
चल
और
रहा है तो उसके,
बिस्फॉस्फोनेट
हाँ,
ओरल साथ में नहीं देना।
साथ में नहीं लेना। नो।
हाँ, बिकॉज पैथोफिजियोलॉजी से अगर हम बात करेंगे तो अगर बिस्फॉस्फोनेट्स जो है वो आपका ऑस्टियोक्लास्ट इफेक्ट रोक देते हैं, दे गेट इनकॉर्पोरेटेड इनटू जो आपका हाइड्रोक्सी एपेटाइट क्रिस्टल्स है, तो दे स्टे इन द बोन फॉर अ लॉन्ग टाइम। दूसरा, जो बेसिक, सो इट वर्क्स पेरीपैराटाइड, एट द एंड ऑफ द डे वो पैराथ हार्मोन ही है, उसको सबस्ट्रेट चाहिए, और सबस्ट्रेट ही बंद हो गया तो बिस्फॉस्फोनेट के साथ काम नहीं करेगा। सेम थिंग विद डेनोसोमैब, रैंक लाइगेंड इनहिबिटर है, तो रैंक लाइगेंड बंद हो जाएगा तो अगेन ऑस्टियो हमारे पास एक सबस्ट्रेट नहीं है फॉर द फॉर पेरीपैराटाइड टू वर्क, तो इसलिए टेरिपैराटाइड अलोन एंड देन वी स्विच टू एन एंटी।
एक चीज और बताओ बॉस, ये जो कैल्शियम है ये एलिमेंटल कैल्शियम है या एक्टिव कैल्शियम? कौन सा कैल्शियम कितना एमजी होना चाहिए? मतलब जो 1250 एमजी एलिमेंटल कैल्शियम होता है
हाँ,
उसमें से तो 400 एमजी एब्जॉर्ब होता है ना?
तो यहाँ पर जो हम बात कर रहे हैं वो एब्जॉर्ब, जो आपका एलिमेंटल एक्चुअल कैल्शियम है, जो कैल्शियम एब्जॉर्प्शन है, जैसे 250 mg, अब ये सीसीएम के अंदर 250 होता
हाँ
है या 400 होता है, हम
हाँ।
उसकी बात कर रहे हैं। तो वी व्हेन वी टॉक
उस
अबाउट कि कितना देना है, तो यूजुअली सो जो डेटा है दैट सजेस्ट कि हमको 2.1 ग्राम से ज्यादा एक्सीड नहीं करना। दैट
डेली।
इंक्रीजेस द रिस्क फॉर 17% इंक्रीज होता है रिस्क का फॉर डेवलपमेंट ऑफ रीनल स्टोन्स। यूजुअली हम स्टिक करते हैं टू बिलो 1 ग्राम, इससे ज्यादा नहीं देते। बाकी जो रिक्वायरमेंट्स है
तो
वो डिपेंड ऑन एज एंड
तो
डिपेंड
जैसे
ऑन।
जैसे शेल्कल एचडी आता है उसमें 2 बार 2 तो 800 एमजी हो जाएगा डेली।
हाँ,
तो वो 2 बार दे सकते हैं हम लॉन्ग
दो
टर्म के
बार दे
लिए।
सकते, उसको दे सकते।
और सीसीएम तो फिर तीन। सीसीएम
तीन
तो
बार, चार
मैलेट है
बार।
ना?
हाँ,
हाँ। ठीक है ठीक है ठीक है। थैंक यू।
थैंक यू।
ये तो हर कोई लिखते हैं कैल्शियम। नाउ इनवाइट डॉक्टर आंचल मैम to start with the next topic for today's JC.
My screen visible?
Yes, ma'am, visible.
Okay. So, good evening, everyone. So, the second topic, pharmacological management of osteoporosis in postmenopausal. What our Endocrine Society, they have given the clinical practice guidelines. So, the study was published by Richard et al., University of California, Mayo Clinic in UK, and the European Society of Endocrinology. They got it published in 2019. So, postmenopausal women, 1 in 2 women will experience this osteoporotic fracture, so which will cause pain, decreased mobility, and once you have had fracture, it puts you at the higher risk of having subsequent fractures. So, American College of Physician guidelines, they do drug therapy for osteoporosis for 5 years, but without monitoring bone mineral density during that period. Lack of differentiation in therapy duration between bisphosphonate and denosumab, and the recommendation did not include the newer therapies. So alternative perspectives were the endocrinology societies differed in their recommendations for pharmacotherapy for postmenopausal osteoporosis. And this presentation highlights the need for optimized treatment strategies to effectively manage postmenopausal osteoporosis and reduce fracture-related complications. So it includes 2 systematic reviews, which included 107 randomized control trials, including 193,987 postmenopausal women with primary osteoporosis. Mean age was 66 years, and the median follow-up was done for 28 months. The key findings were reduced vertebral fractures, hip fracture, non-vertebral fracture for all of the agents that they used, and we'll discuss them one by one. So they said that review of patient, like we discussed in last presentation, review of patient values and preferences are important because women generally evaluate treatment effectiveness and risk of side effects equally. Convenience was also important because less frequent doses was preferred. Oral medications were generally favored, but less frequent injections were preferred over more frequent oral dosing. Cost and treatment duration was less influential in decision making. And common reason for avoiding menopausal hormonal therapy included fear of having breast cancer and not wanting the return of uterine bleeding. And calcium and vitamin D were perceived as safe and natural. So these are the figures which compare, the first figure is hip fracture, and you can see that all of them, other than just alone calcium, reduces the chances of having hip fracture. Then vertebral fracture, vitamin D is closest to having the highest relative risk alone, but all of them, other than that, reduces the vertebral fracture. And then non-vertebral fracture is ibandronate is the only one which does not reduce the fracture, a non-vertebral fracture, but other than that, everyone reduces the risk of having non-vertebral fractures. So who to treat? They recommend treating postmenopausal women at high risk of fractures, especially those who have experienced recent fractures with pharmacological therapies. So then what's the evidence for who to treat? The primary goal is, of course, reduction of osteoporotic fractures. The treatment eligibility is determined by bone mineral density T-scores and FRAX scores. So there are 52 national osteoporosis guidelines across 36 countries. Some use fixed BMD scores. Some use 10-year fracture risk threshold. What the US recommendation was pharmacological therapies recommended if you have hip or vertebral fracture, if the T-score is less than minus 2.5 at lumbar spine, hip or femoral neck, or if it's between -1 to -2.5, then you have to see a 10-year FRAX risk, which should be more than 20% for major osteoporotic fracture or more than 3%. So this has been discussed already. This is the questionnaire which you click and then a score comes for the FRAX when you use a FRAX calculator. This is just since they said that country-wise there are guidelines, I was just interested, what our Indian society say about it. So I just took a table from a guideline published in 2021, which says the similar thing, that if you have a vertebral or non-vertebral fracture already, if T-score is less than -2.5, or if it's between -1 to 2.5, then you have to go by the FRAX scores. But in diabetes patients, then threshold should be increased to less than -2 only. So importance of a recent fracture. A recent fracture within 2 years predicts a much higher risk of another fracture. Treatment should therefore be started promptly, and therapy may be initiated in 2 weeks or more after hip fracture. So comprehensive approach, we'll discuss actually one by one. So first is our bisphosphonates. They recommend initial treatment with bisphosphonates to reduce the fracture risk. Abandonate is, as we saw in that chart, is not recommended to reduce non-vertebral or hip fracture. When patient on bisphosphonate, risk should be assessed every 3 to 5 years. And who continues to remain at high risk, they should continue their therapy. But if they are on low to moderate risk, then they can be considered for bisphosphonate holiday. So available bisphosphonates are oral alendronate, rezidronate, ibandronate, and IV's zoledronic acid, and also ibandronate. So special evidence for zoledronic acid. A large trial in men and women after hip fracture found that annual zoledronic acid reduces all clinical fractures by 35%, and overall mortality is reduced by 28%. So, here all the bisphosphonates are compared not with each other, but versus placebo. So you can see that alendronate and zoledronic acid reduces the risk of having vertebral fracture and hip fracture close to half of it. So beyond 5 years, bisphosphonates are unique because their benefits continue for several years after treatment is stopped. So there was a trial, flex trial, in which 10 years versus 5 years patients were studied. The women who stopped alendronate after 5 years gradually lost their BMD. And after 5 years, 50 to 75% BMD was gained during the therapy was lost. BTMs also is also increased after stopping. So continuing alendronate reduced the vertebral fracture significantly, but did not reduce the risk of having hip or non-vertebral fractures. Zoledronic acid was studied 6 years versus 3 years. After discontinuation, BMD declined more slowly, and BTMs also increased more slowly. So Continuing treatment significantly, of course, reduced the vertebral and non-vertebral fractures. So among the other two, evidence is limited, but in the TRIO study, they studied 57 women in which that participant received 2 years of treatment followed by 2 years without treatment, and they did not find any significant difference compared to the other bisphosphonates. So bisphosphonate treatment holidays. Once you have given the treatment for 5 years, there could be a risk of adverse events like especially atypical femoral fracture and osteonecrosis of jaw. So that's why they ask the patients to be put on the treatment holidays. So what they recommend is temporary drug holiday for low or moderate risk after 5 years of oral and 3 years of IV. So, but patient at high fracture risk should be continued on bisphosphonates, or they may be switched to other osteoporotic medication. So studies of alendronate and zoledronic acid show that after stopping treatment, BMD declines over 3 to 5 years, and BTMs remain suppressed initially, but they increase gradually. So they tend to have their effect stayed for at least 3 to 5 years. So coming to the second, denosumab, they say that it is an alternative initial treatment. Recommended dosage is 60 milligrams subcutaneously every 6 months. Effect on bone remodeling reverse after 6 months. So thus, drug holiday, they do not recommend treatment interruption because, as soon as you stop it, the treatment benefits are lost. So on denosumab, fracture risk be assessed after every 5 to 10 years. And women who continue to remain at high risk of fracture should either continue the denosumab or treat it with other therapies. And its administration should not be delayed or stopped without subsequent antidisruptive. So you need to put the patient on any other osteoporotic medication when you plan to stop it. So let's see the evidence. There is a meta-analysis comparing it with the placebo. So it says that it reduces the vertebral risk by 68%, 39% in hip fractures, and 19% non-vertebral. There was a freedom trial which showed the benefit of over 3 years in an RCT, which was placebo-controlled. Subsequent 7-year freedom extension, all participant on denosumab. There was no placebo group in that. During that year 4 to 10, fracture rates remain consistently low, as you can see, close to only 1 to 2%. And this suggests that denosumab maintains its fracture protective effect up to 10 years. However, there is no published data beyond 10 years. But its only limitation is the bone mineral density declines rapidly after stopping it. So treatment should be individualized. Talking about giving denosumab in chronic kidney disease patient, the main limitation is risk of hypocalcemia. So unlike bisphosphonate, denosumab can be given in CKD. And bisphosphonate also, I think with the dose adjustment, we can give it. But this was the paper published in 2019. So CKD stage 1 to 3, it increases BMD and reduces fracture risk. Stage 4 improves hip bone mineral densities. Stage 5, patient were not studied in this trial. And severe CKD patient on dialysis have a higher risk of post-treatment hypocalcemia. So minimize this risk. We need to ensure adequate calcium and vitamin D intake. We need to measure these 14 days after injection and before every dose. And we need to educate the patient about having signs and symptoms of hypocalcemia like muscle cramps, tingling, numbness, and seizures. So adverse events, 3-year freedom trial, there was no significant increased risk of any significant side effects, but up to 10 years, when they studied, there was no increase in overall adverse events. There were rare skeletal complications like osteonecrosis of jaw. They could find only 13 cases, and atypical femoral fracture, only 2 cases over the span of 7 years. So meta-analysis showed small increase in serious infections like cellulitis, eczema, hypocalcemia we just discussed, so which is more common in the patients having comorbid illness like CKD, vitamin D deficiency, or high baseline bone turnover. So rebound effect we discussed, stopping the denosumab, the rapid increase in bone turnover markers like CTX, P1NP is seen within 3 to 6 months, and BMT back to pre-treatment level within 2 years. So increased risk of multiple fractures. So dose should not be delayed. It should be given every 6 months. And if we stop it, we should need to start any other anti-resorptive therapy. So coming to teriparatide and abaloparatide. So in postmenopausal women with osteoporosis, they recommend to those with severe or multiple vertebral fractures, they recommend the treatment up to 2 years. And the women who have completed a course of teriparatide, we recommend treatment anti-resorptive osteoporosis therapies to maintain the BMDs. So evidence says mechanism of action, of course, we know it's an anabolic agent. It stimulates new bone formation. And when given as daily intermittent injections, it reduces the vertebral fractures by 74%. So, maximum so far, whatever drugs we discussed, and decreases non-vertebral by 39%. More effective than risedronate in reducing vertebral and clinical fractures. Abaloparatide, it also reduces vertebral fractures by 87% and non-vertebral by 46%. So animal studies show that increased risk of osteosarcoma if you increase the treatment to more than 2 years. But human data, which was more than 1 million teriparatide users, they did not show any increased osteosarcoma risk. Of course, there is some side effects like dizziness, leg cramps, mild hypercalcemia. But serum calcium should be checked before treatment, and these agents should not be used in patients with hypercalcemia. And after stopping therapy, benefits are also rapidly lost, which with decline is seen in just an year. Patients should immediately transition to an anti-resorptive drugs like bisphosphonate denosumab, like we just discussed. Use after bisphosphonate. Teriparatide, they say, remain effective even if patients previously treated with bisphosphonates. The response might be slightly delayed. Fracture reduction remains comparable to that seen in treatment-naive patients. So they say that bisphosphonates remain first-line therapy in most patients with osteoporosis. Anabolic therapy is preferred for very high fracture risk or those who continue to fracture or lose bone despite anti-resorptive therapy. So romosumab is another anabolic option they have mentioned, but we know that it's still not available in many countries. Then the next option is selective estrogen receptor modulators. They say that they recommend raloxifene or bezidoxifene to reduce the risk of vertebral fracture, but patient characteristics should be low risk of DVT when bisphosphonate or denosumab are not appropriate, or there is a high risk of breast cancer. So both the drugs, I've compared. Both reduces risk close to 40%. They do not significantly reduce the risk of hip or non-vertebral fracture. So they are helpful only in the vertebral fractures. They have side effects like thromboembolism, flushes, and leg cramps. And this an extra line about the bezidoxifene. It is approved for osteoporosis in several countries, but still not available in other countries. So clinical consideration for raloxifene. It has a breast cancer benefit. It reduces ER-positive breast cancers during the treatment with protection persisting for at least 5 years when the treatment is ends. So this benefit should be considered when you discuss the treatment option with patients. Ideal candidates are young postmenopausal women with osteoporosis who do not have vasomotor symptoms, women at increased risk of breast cancers, and long-term safety concerns like AFFs have not been clearly linked to raloxifene. Similar adverse effects. Venous thromboembolism is similar to menopause hormonal therapy. So it should be used cautiously if you have to, and it should not be used in patients with prolonged immobilization. Then menopausal hormonal therapy and Tibolone benefits. It prevents all kind of fractures like vertebral, non-vertebral, and hip. You can use estrogen alone in patients who have had hysterectomies. Appropriate candidates less than 60 years old or less than 10 years since menopause. Low risk of DVT, unable to use first-line agents, have bothersome vasomotor symptoms, and they should not have any contraindication to hormonal therapy like MI, stroke, or breast cancer. So evidence comparing both, they both decreases the fracture risk of vertebral by 34%, 44% Tibolone, hip fracture no reduction, and 29% by menopausal hormonal therapy. And then limitation, similar, increased risk of stroke, bleeding, vaginal discharge, And long-term follow-up from Women Health Initiative, most risk decreased after stopping therapy, and estrogen alone had lower risk, especially breast cancer, than combined estrogen progesterone therapy. And talking about Tibolone, LIFT trial found lower breast cancer risk, but Liberate trial found increased breast cancer recurrence in women who have had history of breast cancer. So you can't use Tibolone in those. Additional benefits of hormonal therapies, relief of menopausal symptoms, lower diabetic risk, and reduced colon cancers. So then next agent is calcitonin. They say that nasal spray should be prescribed only patients who cannot tolerate the first-line agents or on whom these therapies are not considered appropriate. The evidence says that calcitonin reduces the risk of vertebral fractures by 46% when you compare it with placebo, but did not reduce the hip or non-vertebral fractures. Studies of nasal spray calcitonin were not designed to calculate the dose, but there's a proof trial which says that 200 national international units actually reduces vertebral fractures, but there was no benefit with decreasing the dose to 100 or increasing it to 400. Limited evidence say that calcitonin may help relieve pain from vertebral fractures based on small RCTs. Patient who cannot tolerate first-line agents, nasal spray calcitonin may be used and is well tolerated. Recent evidence has raised concern about its long-term safety, though, because there is increased risk of cancers, including prostate, liver, and other malignancies. And it's not mentioned here, but I have also read the papers of these nasal spray causing the nasal perforations. So due to these safety concerns, European Medicine Agency and Health Canada have withdrawn nasal spray calcitonin from the market. Coming to calcium and vitamin D, they should be used in adjunct and alone if the patient cannot tolerate any of the therapies we have discussed so far. Calcium alone, we saw there was no reduction in vertebral or hip fractures, but they do reduce non-vertebral fractures by 37%. Vitamin D alone also similar, but if you use them together, they may reduce hip fractures by 19%, but no significant on vertebral fractures. So strongest evidence for hip fractures comes from nursing homes where women were aged more than 70 years and had vitamin D deficiency, where hip fractures were reduced by 33%. WHI trial, they say it only benefits if the patient adhered to calcium and with taking vitamin D daily. And so current understanding is calcium and vitamin D do not effectively prevent vertebral fractures, but these supplements are considered standard supportive therapy rather than any primary treatments. So calcium supplements and cardiovascular risk. Some meta-analysis suggests small increase in the risk of heart attack and stroke with calcium supplements alone without vitamin D, but some other has found no associations. So far overall evidence is unconclusive. Vitamin D supplementations up to 4,000 international units per day is generally safe, with hypercalciuria being the main concern. High dose intermittent vitamin D say that actually has been associated with increased risk of falls and fractures and should be avoided. But newer meta-analysis show again inconsistent or no benefit of vitamin D alone for fractures. And also there is a risk of kidney stone. Combining high dose calcium supplements with vitamin D may increase the risk of kidney stones. By very high, they mean about 2,100 milligram per day was associated with 17% increase in kidney stones. So they recommend encouraging dietary calcium. Keep calcium supplements intake below 1,000 milligram per day. Total calcium intake should be 1,000 to 1,200 milligram, consistent with Institute of Medicine recommendation. All postmenopausal women with osteoporosis should have their vitamin D level measured, and it should be at least 20 nanogram per ml or 50 nanomoles per liters, and Endocrine Society recommend it should be more than 30 nanogram per ml or 75 nanomoles. And vitamin D levels can be achieved about with 1,000 of international units of vitamin D daily. So approaches, primary goal we know to reduce the fracture risk. So we have discussed that, adequate calcium, vitamin D, performing resistance and balancing exercise, stop smoking, and minimize the use of medications that harm the bone like glucocorticoids, minimize the dose, and other medical conditions. So, choosing the right medication should be based on drug availability, cost, patient preferences, Like they say bisphosphonates is first line because they're effective, inexpensive, and have long-term safety data. Loxapine may be preferred in women who have high risk of breast cancer. Denosumab, zoledronic acid may be better option in women with GERD because we know oral bisphosphonate causes this problem of having GERD. Anabolic therapy may be considered first line in recent vertebral fractures. And one osteoporosis medication should be used at a time, apart from calcium and vitamin D, rather than combining drugs. When should you switch the therapy? When there is a poor tolerance or side effects to one medication, cost or availability, inadequate treatment response. Possible indicators of treatment failure: significant bone mineral density loss over 2 years, and insufficient reduction in BTMs if you measure it. 2 or more fractures while on treatment, even one fracture during the effective adherent therapy. And before labeling treatment as failure, clinicians should exclude secondary causes like multiple myeloma or other medications. So when should you consider anabolic therapy? Switching from anti-resorptive therapy to bone-forming therapy may be appropriate in women with recurrent vertebral fractures, continued fracture despite long-term potent anti-resorptive treatment, or serious complications, which we just discussed. And treat to target approach. Achieve a predefined BMT target, escalate to more potent therapy if target is not achieved. Stop treatment if the patient is having fracture risk become, very, very low. So this is a chart they have shown. All postmenopausal women, they recommend lifestyle and nutritional optimization. Determine the 10-year FRAX score risk. If the patient is in low, moderate risk, then you see if it's a low risk or moderate risk, or if patient is high risk. If the patient is low risk, you can just reassess fracture risk every 2 to 4 years. And the moderate risk, either you can reassess or choose the patient to be started on bisphosphonates. But if patient is high to very high risk, then you have to choose either from bisphosphonate, denosumab, teriparatide, along with calcium and vitamin D therapy. So on bisphosphonates, if patient has come to low to moderate risk category, consider drug holiday. But if patient is high risk, then you continue to have the therapy. On denosumab, when you switch, consider bisphosphonates. But if patient is high risk, continue the therapy. Then in patient who is intolerant to these first line therapies, then see the age of the patient. If the patient is less than 60 years or less than 10 years past menopause and low VTA risk, or patient is more than 60 years. If more than 60 years, then selective estrogen receptor modulators, calcitonin, tibolone. And if the patient is less than 60 years and no vasomotor, then selective estrogen receptor modulators. With vasomotors, you have to consider hormone replacement therapy. Optimal duration, we discussed that. Impact of stopping, we discussed that. Osteonecrosis of jaw, just a word about it, that what it means is if for more than 8 weeks, you have exposed jawbone and, occurring after invasive dental procedures. So general risk is 0.001 to 0.01%. But after 4 years of oral bisphosphonate therapy, it increases to 0.2%. And following tooth extraction in bisphosphonate user increases to 0.5%. So American Associations of Dental and Oromaxillofacial, they said that they do not recommend stopping bisphosphonates before any dental procedures, but they recommend considering a 2-month bisphosphonate drug holiday before any dental surgery, especially if the patient is on bisphosphonates for more than 4 years, along with a routine dental care. So how do you manage it? Stage 0 to 2, conservative treatment with antibacterial mouth rinses. Stage 3 needs surgical debridement. And experimental treatments like teriparatide, PRP, laser, they have shown some promise in case reports, but more control studies would be required. And then atypical femoral fractures, then when you have a fracture of femoral shaft, it was first linked to bisphosphonate use, but now it has also been reported with other osteoporosis medications. So how do you recognize it? With the typical symptoms of persistent thigh or groin pain, or pain during or after weight-bearing activities. So pathogenesis is unclear, but they say the contributing factors could be femur anatomy or genetic predisposition or ethnicity. So that is confirmed with the radiographs showing But the studies that confirmed AFFs with radiographs consistently show that they are rare despite the potential association with long-term bisphosphonate therapy. How do you monitor? You do BMD every 1 to 3 years. You monitor BTMs, which is an alternative way of identifying poor response. You don't use it to diagnose, but just a marker if you want to just monitor your therapy. So if you want to monitor, what should you expect? When you usually with alendronate, lumbar spine BMD increases 7%, and then you can see 3% with acetronate, other therapies, alendronate 7%, denosumab 8%, and teriparatide 13% increase. That's why they're so beneficial in vertebral fractures. So how do you interpret BMD changes? If it has been stable or increasing, it's a good treatment response. Significant change should exceed the least significant change, which in spine is 4 to 5% and hip is 4 to 5%. And why should you monitor it? It helps you identify medication compliance, secondary causes of osteoporosis like multiple myeloma, drug usage, etc., or loss of treatment effect after stopping therapy. So practically, they say if possible, use same DEXA machines, same technology technician, because degenerative spinal changes or new vertebral fracture can actually falsely increase, like osteophytes and all. They can falsely increase the BMD. So BTMs, they say that if you monitor, they show much earlier changes than BMD. Alendronate CTM, it decreases by 80%, P1 NP decreases by 60%. So good BTM responses, CTX should decrease and P1 NP should increase. Timing measured before starting the treatment and every 3 to 6 months. Least significant change for BTMs, serum CTX should be about 56% and P1 NP should be about 38%. How do you collect it? Collect in the fasting sample in the morning and use the same lab and assay for follow-up. If BTMs do not change, check the medicine compliance, secondary causes, similar things. Key exam points, we discussed this. Takeaways, zoledronic acid, greatest reduction in vertebral and hip fractures. Alendronate and risedronate are effective oral options. Abandonate only primarily for vertebral fractures. Benefit persist after discontinuation, so drug holiday could be an option. And the strongest evidence for long-lasting effects come for alendronate and zoledronic acid. Additional protection against vertebral fractures, while benefits for hip and non-vertebral after prolonged treatment are less certain. Bisphosphonate drug holidays can maintain much of the fracture protection while reducing the risk of side effects like osteonecrosis or AFF. Denosumab, they say, is an alternative. Dosage we discussed, they act rapidly, bone turnover within 1 week and provide strong anti-fracture efficacy. Benefits reverse after 6 months if not taken on schedule. Thus, drug holiday not recommended. Fracture risk can be assessed after 5 to 10 years. If high risk of fracture, should either continue denosumab or treat with other agents. Overall, its benefits outweigh its risks. Teriparatide up to 2 years. And once you have completed, switch to other therapy. SCRM, with a low risk of TVT, high risk of breast cancer, and bisphosphonate and denosumab not appropriate, then you can use to either raloxifene or basidoxifene. Hormonal therapy, we have discussed, what kind of patients. Calcitonin only in patients who can't tolerate first line, calcium and vitamin D as an adjunct. Moderate vitamin D doses, discuss that. Screening, and there is a consensus that calcium vitamin D should be added to all osteoporosis treatment regimens to enhance mineralization and maintenance of bone mass in high-risk postmenopausal women. Thank you. So,
Thank you, ma'am. Yours was more difficult article,
extensive.
extensive. मतलब it was थोड़ा clinical practice में इसको ढालना मुश्किल है. मनोज सर वाला आर्टिकल थोड़ा समझ में ज्यादा आया.
But the
वो
risk,
easy था, ये
risk
difficult
category
था.
is different. Na? Risk category, wo patients mainly will go to Dr. Aanchal. and other endocrinology,
Anji,
glucocorticoid dependent. These are our patients which comes to us with a low back pain. While we diagnose lumbar canal stenosis, facet arthropathy, patient has osteoporosis, and we might need to treat along, with that. So I think that needs to be our focus. What challenges Dr. Anchal can, because this is a little older article, but I think we, some participant is requesting to start Zoom AI. I don't know. So that is, Dr. Anchal can tell us more about, is this how relevant is in today's context?
Ma'am, so there are a few things that have changed. Of course, romosozumab is there, so it
Yes.
wasn't in 2019.
Yeah.
So the categories have shifted. There are so there is Indian data as well for FRAX, but this Indian data is not from India; it's from Singapore. And the data that we have a separate data. So in India we usually use T scores. We don't use FRAX, and it has not been adopted officially. There is a FRAX scoring as well. But so Dr. Amrish Mittal has published an article. So it says that in case in India, if we have a FRAX score of so major osteoporotic risk is more than 10% and hip fracture is 3%, then we need to consider the patient for treatment. Again, with postmenopausal osteoporosis, it's very important. So again, if the patient is at high risk of fractures or at imminent risk fractures, frailty fractures, or with trivial fractures with trivial trauma, we need to consider the patient for, again, anabolic therapy. So anabolic therapy goes up above everything else if the patient is at high risk. If the patient has the recurrent vertebral fractures, even on treatment with bisphosphonates, I think you've already covered that. Again, a patient who had an early menopause. So this is something that which is very common and is certainly overlooked. Is that patients who have endometriosis, they undergo to salpingo-oophorectomy and early menopause. Same with patients who have premature ovarian failure. So they are usually not supplemented with HRT, and which they should be. So they have vasomotor symptoms. So vasomotor symptoms are still just symptoms which last probably 2 to 3 years. And after that, it's physically, of course, it's physically patient has an issue with vasomotor symptoms, but more than that, there is cardiovascular risk which happens with the early menopause and also the bone risk. So these patients need to be evaluated for osteoporosis. They need to be started on HRT if there is no increased risk of any VTE or any risk factors. So patient is not a smoker, no history of any prior thromboembolism. So we need to start such patients on HRT therapy. So this is where all of this becomes more relevant. And since so there is also in males, so male part is certainly is something which is overlooked majorly because so males are in India. So if we consider alcohol is a major issue which can lead to hypogonadism and lead to osteoporosis as well. We need to evaluate males for secondary causes of osteoporosis, even females for that matter. So somebody who presents with a non-menopausal female presents with recurrent vertebral fractures, we need to evaluate before starting just based on the DEXA scan and the T-score values before starting her on any anabolic or anti-resorptive therapy. We need to rule out secondary causes. The patient could have hyperparathyroidism. The patient could have Paget's disease, some malignancy which is ongoing undetected. So that's where so you spoke about bone turnover markers. So bone turnover markers, that's where the bone turnover markers become relevant. So CTX is a marker for resorption and P1NP is a marker for bone formation. So what happens is if the both are raised, we usually suspect hyperparathyroidism. We need to have a baseline test for this, and then you spoke about the suppression, the amount of suppression that happens. Yes, of course, that needs to be the treatment to target. That is what we talk about. We need to suppress. There needs to be a suppression of bone turnover markers if the patient is on anti-resorptive therapy. If the patient is an anabolic, of course, P1NP is going to increase, and that is another marker that the P1NP increasing means that the anabolic therapy is working. CTX suppresses because there is just depression of osteoclast and the resorption gradually starts decreasing.
Like with the vertebral fractures, they say that you should start anabolic therapy. But what about those patients who do not have fracture, but they come in the high category? Do you choose anabolic therapy or bisphosphonates for them?
Yes. So here there is an NOGG guideline. There is National Osteoporosis Guideline. So it does not consider FRAX score that much. It increases the risk as the age goes on, the risk factors increase. So if we are consider specifically the T score, so up to 2.8 we can give anabolics because we are treating to a target, right? So we do not expect that if a patient has a T score of say -3 and we start the patient on bisphosphonates, we do not expect that the patient is going to reach a target of 2.5 or 2 for that matter. So in those cases, we start with anabolics. So 2.8 up until 2.8, we can start with we can start with antiresorptives. From 2.8, anything above that, we would want to start the patient on either romosozumab is better than teriparatide in postmenopausal women. So 2.8 above, we would want to start on romosozumab or teriparatide and then follow it up with some antiresorptive agent.
Okay. All right. Thank you. Thank you for the input. Dr. Deep?
Anji ma'am. Any questions in the chat box? नहीं है. Anyone wanna ask some question to Dr. Aanchal or to Dr. Aanchal ma'am or to Dr. Manoj?
I think I'm glad we discussed it because I think it came to my mind because we keep seeing those patients with low back pain, but their pain is not coming from, either facet or it's the osteoporosis which is causing the back pain. So we need to be, all pain physicians need to be well aware of that cause of having osteoporosis as a cause of back pain. And until you treat it, no intervention, no injections would help as much.
And if we go by the data, it's not just vertebral fractures. So hip fractures, if we consider mortality, have a 25% mortality within 1 year.
Oh.
So that's where treating osteoporosis is very important, especially somebody who has a prior history of hip fracture or vertebral fracture, because that increases morbidity and mortality as well. So even in patients, so romosozumab has so it has a caveat that you cannot use it in somebody who has a history of MI because it increases CV risk. So, but still, the severe risk increase is so small as compared to the prevention of mortality or prevention of fractures that it is causing, that it is still prudent to use it if the patient has had a history of CV risk or history of MI or stroke more than 1 year back. So osteoporosis is something which is overlooked very easily. I think we even with our own parents, we don't usually go for this, but this is something that we should be doing regularly.
All right. Thank you so much staying us with so late and all the participators still staying. So Dr. Deep, we can wrap up, I think.
Anji.